We're going to move on now to Dr. von Allmen, who's going to talk to us about intussusception.
Great, thanks, Todd. So Dr. Wolkin and I are going to bang through a few quick hit topics.
Okay.
This one in particular, talking about intussusception, I was at a APSA case presentation session several years ago that Dr. Harmon was doing and presented a case of intussusception, and I was really struck by the heterogeneity of the practice patterns for how we actually treat intussusception. And it's something that I think has changed certainly dramatically since I was a fellow, which was way, way too long ago. But even just in the past several years, there have been this ongoing change in how we manage intussusception. So I'll be very interested to hear from our colleagues across the country, but also internationally, how they manage this relatively common problem. So if you start with a standard case, a 2-year-old who presents to the emergency department with colicky abdominal pain, a little bit of bloody stool, and a palpable mass in the left upper quadrant. On exam, it's hemodynamically stable, actually relatively comfortable with no peritoneal signs. So how would you work that patient up? And how do people, what's the next test that you would get? Or conceivably, would you take that patient, his kid with classic intussusception, would anybody take them directly to the operating room?
So who here
Who gets plain films?
What's that?
Who would get a plain film?
Who would get a plain film? Right, that's a good question because I've never had a patient that didn't have one. So,
right, but the question is you can't rule out intussusception on a plain film.
Right.
So does it help you or not? And I guess that's one of my pet peeves is we get lots of tests that don't really help us, but we get it just because we get it, and I'm as guilty as anybody else.
At our place, the radiologist will refuse to do an enema without a plain film to rule out free air. So there you go.
Yeah, radio.
So our faculty here, our radiologists, will just take them for the enema, and they shoot a flat plate, basically in fluoro, right before they start, and they use that as their substitution in the fluoro suite, but not a separate set.
Did I miss that you got an ultrasound already?
So that was exactly my next question.
I would
is
get the ultrasound and
you're saying
bypass
going
the
for the
plain
enema,
films.
but how many people would get an ultrasound to confirm the diagnosis? What test are you going to use to confirm the diagnosis?
So who here would not get an ultrasound? Would anyone not get an ultrasound to confirm the diagnosis? Looks like you're going to get those two.
So most people are going to get an ultrasound, which is what we would do for sure, is get an ultrasound in a patient with a great history, and all the classic physical findings would still get an ultrasound to confirm the diagnosis before then going to radiology for a therapeutic intervention. And I'd be very interested to know from our international colleagues, in particular, do people do ultrasound, saline reductions under ultrasound, or do either contrast or, I think in most places here, at least in our institution, use air as the contrast to do reductions with air?
So Alex, tell us what we found when we asked that question online.
This was kind of sparked by a randomized control trial that came out of China within the past couple of years, where they compared directly the ultrasound-guided saline enema versus the air contrast enema, and found that the ultrasound-guided had like a 96% success rate compared to like 83% for air contrast enema. So just asked why we weren't doing these ultrasound-guided ones, and posted it to our Facebook group, and everywhere that wasn't the United States said, we are doing these ultrasound-guided saline enemas. What are you talking about? So it seems like it's pretty much just a U.S.-specific thing that we're still doing, the air contrast.
Mm-hmm. Yeah.
And it's sort of, so maybe that plays into the next question, which is being answered here as we speak, which is how many attempts at reduction do people allow the patient to have before proceeding to something more invasive like surgery? And in that study that you quoted, how many attempts were made to get that 90% reduction rate?
I don't recall how many they had made, but I know that the saline group had a lower intraluminal pressure compared to the air contrast enema group. It was like 88 millimeters mercury compared to 120 of the air contrast.
And 120 is what we use, which Dr. Godegal just informed me before. Our radiologists use 120 as their pressure limit. Yeah. But how many, I'd be curious from the people here, how many, the poll says 62% say 3 attempts, 2 attempts and a quarter of them, and 10% would only do one attempt.
Let me hit, even while we're waiting for that, on the basic assumption that 3 years ago we presented whether or not you do that at all. A few years ago, our institution in Akron, I work at 2 institutions, in Akron, they would not repeat it. If it did not reduce, I was going to the operating room. And after this being presented multiple times on this forum, we now repeat it, and I would say we do it about 3 times. Is there anyone here that is in an institution that does not do another attempt?
At least one other attempt.
At least one other attempt.
Our protocol
everyone's
in Cincinnati is 3 attempts.
3 attempts, Mac?
Just a comment there. Two ways the first reduction fails. One is you move the intussusceptum all the way over mid-right colon. They can't go farther. They're not going to go farther. And you know there's still an intussusceptum there. The second way they fail is they actually reduce the whole thing, but it doesn't reflux up through the ileocecal valve. So the patient is completely reduced, but that doesn't meet their criteria for being able to say it's reduced. And so when you repeat the enema, one time you're trying to really reduce what was left, and another time you're just trying to confirm that they actually did what they didn't confess to do in the first place.
Because you need the edema to settle out. Whit?
I also think that you've got to see progress with the attempted reduction before you would persist on with another 1 or 2. That is, if you try the reduction and it doesn't really move, then there's no, in my mind at least, there's not a real indication for trying it again.
Just to add what Mac was saying is if you do reduce it all the way and don't get reflux, those patients will typically, their symptoms will go away. So you know that you've actually clinically, you can safely watch those patients, or you can just get another ultrasound to confirm that. So I think that radiographic criteria of reflux in the terminal ileum for full reduction doesn't really need to.
I want to challenge you on that. So I'm not challenging you, but make sure I understand you. Hold on. So if they do a contrast enema, an air enema, and it gets to the ileocecal valve, but no air refluxes into the small bowel, you would just follow symptoms. You would not need a confirmation other than that or ultrasound that they've successfully reduced the child.
That's correct. We actually studied that, and initially in our early series, we repeated all those contrast enemas, and they were all normal at that time the next day. What we found was really the symptoms. If you bring them back, they continue to have that crampy abdominal pain was the key. Now it's easier with the ultrasound that you can check.
So the key statement you made is before you would bring them back the next day.
Yes.
So how long do they have to be symptom-free? Because patients with intussusceptions, as I presented this child, can be essentially symptom-free and still have their intussusception.
What we found in our study was that they continued to have very similar recurrent colicky pain, as if we didn't do anything to the intussusception. We did reduce it partly, but we didn't get it all the way. Those that we reduced all the way and didn't see the reflux, those patients were completely asymptomatic.
So Chuck Bro from Grand Junction, Colorado, has a question. Are the 3 attempts all like they do it, it doesn't go, and then they do it again right then? Or are you talking about like a time lapse between the reductions, and how long is that time lapse?
We usually have a time lapse and we let them for an hour or 2.
An hour or 2.
And then redo the study.
Yeah, we do.
I think the time lapse is it depends on what time the first one was done.
If it's 3 a.m., the next one will be at 6.
Or 7.
And I have one of the just true confession. I think early on in the laparoscopic approach to intussusception, I think many of our early successes, I certainly remember in my own experience, you'd go in and you'd sort of grab the terminal ileum and sort of pull it towards yourself and go,
It was reduced.
look at that. That was easy. But instead, those all fall into that second category
That's
I mentioned.
correct.
It was already reduced. They wouldn't call it reduced, so we operated on them and wrote papers about how great laparoscopic surgery was for intussusception.
In Singapore,
So-
they say they give another shot if it's progressing. So you were going to say something.
I was just going to say, to Dr. Harmon's point, how many people would do this laparoscopically and how many people do it open? And that's the next poll question.
Oh, okay. So, wow.
While people are answering this, we did have a question from the audience. Is there any role for an enema under laparoscopic, like direct laparoscopic like view? So would you
I know
ever
I know
combine the
someone
two?
who does that. Jeffrey Lukish describes that when he'll go in and when he does laparoscopy, he'll put the scope in. So see, when you do it laparoscopically, you have to sometimes pull, which is what we've always been taught not to do. So what he does is he has them do it. He does an on-table air enema laparoscopically, and that helps the operation substantially get it to almost to where you need, and then he can pull a little bit rest of the way.
So it's a combined,
Combined lap.
it's not just to look and see whether it's reduced.
No,
Because
like
if you're going to
they
do that, we
failed.
should learn how to do ultrasound like everybody else in the world and do them with ultrasound guides.
Right. No, this is that they've failed. He's going in to do it, and he uses the push to help him laparoscopically reduce it, which is, I thought, a really smart idea. What I have found, I do it laparoscopically, but what I have found is my success has gone way down since the success of radiology has increased. So as they've gotten better, these cases of going in and going bloop are over. That by the if I'm going to the operating room, they have given it the old college try, and these are often ones that are pretty challenging to do. So
Yeah, the only comment I would make is that I still think it's worth putting a scope in and
Yep.
trying laparoscopically, because if you open everyone, then everyone gets an open operation,
right.
True.
right?
True
Words of
statement.
wisdom. No, because I think it's worth trying. But I agree with you. I think that radiology's gotten a lot better. So the easy ones, they took all the easy ones
They took
away
all the
from,
easy
them-
ones.
from us.
Sounds like Namwen and Arturo Aranda both use on-table air enema during their laparoscopic reduction.
Really interesting.
Yeah.
I was just saying, Dan, like I wonder if the laparoscopy versus laparotomy is also about access to laparoscopy. That
Of
many of the
course.
people who are doing laparotomies are probably maybe in places that don't have access to
Of course.
laparoscopy.
Yeah.
Good point from someone who just came from a location like that. Okay.
And I think, Todd, you alluded to the technique laparoscopically, if it's a pull instead of a push. And I think it's an interesting concept to do both with on-table
Yeah.
air.
Okay.
Or maybe saline. We should be using.
Or saline.
Saline sounds like saline may
Yeah.
work better.
Yeah.
Yeah. I wonder,
In that study I just looked up, it was 3 attempts for
3 attempts, so good.
All right.
So now to the last real issue I wanted to discuss, because I think this has probably been the biggest change in practice, at least for us and for me, is what do you do if you reduce this? Do you admit the patient overnight, observe them for 12 hours, observe them for 6 hours, observe them for 4 hours, or discharge them immediately? And this was, I think, one of the points at the session I mentioned early where I was really struck by, we were at that point still admitting everybody for at least overnight and
Okay, so-
keeping them NPO. And
So we know what you do. What do you do in Indiana? Do you admit them overnight or send them home from the emergency room?
I think there's some variability. And there's not only variability among the partners, but one
Yeah.
thing we have to cope with is that we have, most of our kids come from another place, 2 to 4 hours away, having had a CT scan as the initial study. And if they have any symptoms when they go home, they will go back and they will have another CT scan at that outside facility. So sometimes our reason to admit is because of the local resources
Geography,
available
okay.
to them. And I think that since we've gone to air reduction rather than contrast reduction, they actually have more crampy pain in the first few hours after we do the enema. I think they're more distended with gas than they previously were, and so there's a little bit more symptoms. And the third thing I would take into account is how symptomatic were they before they came in and how challenging was it. So I think there are some good candidates, local kids, not too bad, easy transportation back. They're great to go home.
I'm so
after
glad
short
you made
period.
that point. Just like, it sounds like this is the theme of today, is that it's a tailored approach, that you can do one or the other, but it's a patient-by-patient plan. Fred, do you agree with that? Or?
I would pretty much observe 4 hours on almost everybody.
Okay.
And let them go. I
In
think
the ER, you keep them in the ER.
in the ER.
Yeah.
And then don't admit them.
Okay.
But I think Deb has a good point. There, you have to have a tailored approach to some children. So.
What do you do in Atlanta?
Yeah, we observe them for a little bit in the ED and PO challenge them and send them home.
Okay. Anyone here have other comments to make? Does anyone admit them overnight routinely here? Okay. Yeah. Huh? Not anymore. And if
So-
I did, I'm not admitting it anymore because I keep.
so our protocol is that a 4-hour observation followed by a PO challenge and then discharge home. I think the it can be a challenge sometimes because that requires that there's capacity in the ED to have the patient sit there for 4 hours.
That's right. That's another
And that
problem.
has been if we run into a barrier to that, it's a capacity issue in the ED, not because we don't want to use that as our plan.
So I want to do another variability assessment. We're definitely behind as now
We'll
we're
go
getting back to
fast.
the way these courses usually go. What number do you, well, actually, I'm going to start with you, Alex, because you're the ones that see them in the ED before. What number do you quote the parents, and we're going to go down here, as their chance of recurrence?
Say 10%, 10 to 15%.
What do you say?
I'm going to show you 2 slides, so I won't
Oh,
say
man.
anything.
All right, fine. Well, sorry, this is a pretest. This is a pretest.
I'd say 5 to 10%.
5 to 10.
About 10%.
Everyone here in that range? 10, I see 10, I see 6%. Wow, definitely you're right.
Yeah.
7.5.
So, yeah.
5%, okay. All right.
All right,
sorry.
so just to move along, to talk about a couple of studies that looked at the 4-hour observation primarily. This was a study where they looked at 51 patients, I think 52 patients, and bottom line is there was no difference in recurrence rates. However, their recurrence rate was 15 and 16% respectively for patients admitted overnight and patients observed. So a little bit higher than most people suggested here. I think that's actually a little bit higher than most people would quote. There was no difference in the time to recurrence, no difference in adverse outcomes, and that was with a 4-hour observation. Obviously, if you do that, your length of stay is going to be a lot shorter than if you admit the patient overnight. So their conclusion was there was no increase in adverse outcomes with a short observation for an uncomplicated hydrostatic reduction. The other, and this was their protocol, which we won't go through, but basically it's just that. If you're able to reduce it and confident that it's reduced, observe for 4 hours in PO challenge and discharge. This other study was a systematic review with a meta-analysis. It looked at, there were 10 papers where they had enough data to compare the two. They also found that there was essentially no statistical difference in recurrence rates or return to the ED or need for operative intervention or mortality, and obviously, again, a decreased length of stay. The recurrence rate in this study was 6 to 8%, so much more in line with what most folks had suggested in the room. So the key points are outpatient management after an intussusception, after a reduction is safe. There's no difference in most of the outcomes that we measure, but you significantly reduce their length of stay and costs and everything else.
What do you do with like a small bowel intussusception that you see incidentally?
If it's incidental, I would observe it. If it's a patient who's post-op, I would operate. I would put a laparoscope in or operate on. But we see them all the time. I mean, it's not uncommon with a CT scan or something for them to call that, and I wouldn't do anything with that because I've never found that I had to do anything about that.
You could probably give gastrografin.
We can talk about that later.
Okay. All right. So that was great. Of course, the things we all deal with the most get the most discussion, so that was great.